Summit. I'm Professor Öztekin Otto, Chairman of Cardiovascular Surgery Council and President of Heart and Health Foundation of Turkey. This session has been prepared by Council for Cardiovascular Surgery. The broadcast of this session will be done beside the AHS by the unique platform of Heart and Health Foundation of Turkey, namely acardio.com. If you are following from acardio.com, you can ask questions by pushing the button at the baseline and write your questions, and I will see the questions and direct it to the lecturers accordingly. Our today's session is on all controversies in aortic surgery. It will be a really very interesting session. We will start with the first talk on total arch replacement the best surgical approach for type A dissection. The lecture will be given by Professor Manuel Castella, who is the chairman of cardiovascular surgery department in Barcelona, University of Barcelona, Spain. Please, Manuel, microphone is yours.
Okay, thank you very much, Dr. Otto. It's a pleasure and an honor to be invited in this symposium. I want to thank the organizers. I'm going to share my screen, which is this one, and go to my slides. Can you see the slides?
Yes.
Yes. Okay.
Yes.
Yeah. Well, the dilemma is to replace or not to replace the arch in aortic dissection type A, and I put here on the right. I'm sorry. The to be or not to be, the Hamlet Act 3 Scene 1, because really it's a thing that we know that basically in type 1 A dissection, the one that affects the ascending aorta, the arch and the descending aorta, the more that we replace, the less problems that we will have later on over the years. But also, we know that it's a more complex surgery, and it's there's more mortality in the short term. Okay, so it's this eternal debate. First, many years ago, we were doing only aortic hemi-arch replacement or ascending aorta replacement, but with the new prosthesis, with branches, with the frozen elephant trunk prosthesis, now we have made a change to replace the arch. So, but my purpose here today is to show what is the evidence of changing the arch versus going to a more conservative surgery, the ascending aorta or only hemi-arch replacement. What is the evidence and which are the recommendations for each one of these surgeries? I was surprised because I'm doing a lot of arch replacements, but still the evidence, and these are the guidelines of the 2022, the American College of Cardiology, together with the American Heart Association. So the biggest associations of cardiology in America that still don't recommend arch replacement, and they say that routine total arch replacement is not recommended in all patients. That the recommendation basically is for patients in which have problems in the arch. That is, that the primary tear is in the arch, or there's an arch aneurysm or an arch rupture, or there's young patients with connective tissue disorders in which you want to replace as much aortic tissue as possible. Also, the other thing in which it makes is for us to be more aggressive is malperfusion. It's not well demonstrated that replacing the arch is going to solve always the malperfusion, but we know that there's more tendency for these patients with malperfusion to better get perfused in the liver, in the guts, in any other parts if we reconduct the flow the distal as possible. So these are the main indications in America for arch replacement. And the same happens in Europe. These are the latest guidelines of the European Society of Cardiology, together with the European Association of Cardiothoracic Surgery in 2024, in which they say that with the biggest level of evidence, which is 1 with 1B, is to only replace the hemi-arch for these patients, and only if there's a tear, intimal tear in the arch, or there's an aneurysm in the arch, then to go into arch replacement. As the picture that is on the right, it's a very nice, very dangerous picture of a tear in the arch in which of one of our patients that we had to do frozen elephant trunk. Why is this evidence? This is a Chinese meta-analysis from 2022 of changing the hemi-arch or total arch replacement. We can see here that there's been more early benefits in early mortality with only replacing the hemi-arch than not the total arch, because we are talking of a disease of a mortality that ranges from 13% to 25%, so very high mortality. And this is why that the lowest mortality that we get at the beginning, the better. It's not a thing of TAVI versus aortic valve replacement in which we are talking about very low mortalities. In this one, the mortality is very high, so it's very important that we have early good results. This is about mortality, and this is the late mortality. Look at this. Late mortality, it's favored by total arch replacement. The only thing is that we have already paid a toll of the people, of the patients that died before on the early mortality. So in sum, at the end of mortality, it favors the hemi-arch. And this is another meta-analysis. This is very recent from 2024 that goes specifically for different complications. For example, this is renal failure requiring dialysis. And here is the opposite. If you go towards the right, if that thing goes towards the right, means that benefits conservative switch surgery like hemi-arch or ascending aorta, and if it focus up towards here, benefits the total arch replacement. And you can see that there's less renal failure, significant less renal failure if we go more conservative surgery. This is non-significant because it touches the one, but also about stroke, about prolonged ventilation, about permanent spinal cord injury. Look at this. Sometimes we think that because the patient is doing a distal neurologic problems, we can solve it by changing the full arch. But the changing the full arch also by covering sometimes part of the thoracic aorta, basically in these new elephant trunks prosthesis, which are longer. And if we do the anastomosis in zone 3, which that means that we cover a lot of thoracic aorta, then we might have also more permanent spinal cord injury. Visceral ischemia. This is one of the reasons that sometimes we need to replace the arch because the patient is having visceral ischemia. There's no difference by changing the arch or not so much in this meta-analysis. Reoperation for bleeding, also there's no significant change. And long-term mortality, assuming all mortality, see it's get benefit by only a more conservative surgery. But long-term aortic reoperation, because we replace the full arch, then is less with the more aggressive surgery. I want to focus in this new Chinese prosthesis, the from Microport Endovascular from Shanghai. And this very recent study. This is just almost a year ago. A randomized controlled trial of Fontus versus Cronus prosthesis. We don't have this in Europe. I had to read this paper. The Fontus prosthesis is the first prosthesis that we know, that I know at least, for aortic dissection with a branch, extra branch for the subclavian artery. So that means that we can do the replacement of the arch, but the anastomosis in zone 2, and make no difference with the Cronus, which is the typical of doing the anastomosis in zone 3. There was significant less time, 19% reduction in antegrade perfusion time, but no difference in complications. So it was non-inferior, basically. The only thing of this prosthesis, the Fontus, that it's very nice concept to have the prosthesis that they already have endovascular branches that we don't have to suture. This is very, very nice and very important. The only thing is that there's no evidence that by doing we replace the arch, but we do the anastomosis closer to zone 2, zone 1, or even zone 0, we have better results, because we still have to do the anastomosis of the carotid artery and the brachiocephalic truncus. Because in fact, you see this Fontus here. This is the typical thoraflex that we are using in my hospital. In the middle, this image here, this reconstruction of the CT scan, the anastomosis is in zone 1. With this prosthesis, now we can do the anastomosis in zone 3, 2, or even 1, because we have branches to extend it to search up towards the carotid artery. So, but it's very nice and easier to do the anastomosis closer to you, but there has no been evidence that makes better results than just an hemiarch in which you don't touch any trunk of the aorta. And also there's even this prosthesis, the Jotec Evita, specifically designed to do it in zone 0, because as you can see here on the left, there has one branch that from one branch goes 3. So you can replace the aorta, but doing the anastomosis very close to you. And this is the same company has this other one, very similar to the Fontus, with this branch for the subclavian artery, but unfortunately this is custom made, and this is with the size of the patient and everything. So it's impossible to do it in an acute aortic dissection. It's impossible to do it in an acute setting. These prostheses in Europe are made for aneurysms or things like this. So this is why the Fontus, the Chinese Fontus, is so interesting. But it would be nice to have it with more branches than not only one. And the last thing, and the new things that they are doing, that we are doing in the art for aortic dissection, is this hybrid prosthesis. This prosthesis is the AMDS. This is an open stent in which we suture this open stent in the aorta. And then after this, we put this Dacron graft that we suture to both the aorta and this prosthesis at the same moment. This was very promising, but it's not indicated when there's tears in the arch. It thought that this was going to be okay. This has only demonstrated that it reduces the anastomotic new entry tears in this randomized control trial from 43 to 12. This is very important, because this is one of the problems of only doing our ascending aorta replacement, the distal anastomotic new entry tear. So this is nice. The problem is that if there are problems in the arch, like dilatation of the arch, tears in the arch, or things like this is not going to solve any of these, and we will still have problems in the arch. And the other thing is what it shows here, that it's a 9, I put it in red because it's kind of a complication, 9% of severe kinks or not full expansion of the prosthesis body. And this other study here, I'm going to show it to you. This happens in 9% of the patients. it's true that it has not been shown that that makes any complication in perfusion, distal perfusion, but it seems that this prosthesis, which is specifically designed with very low radial force, this is why this happens. This has less radial force than any other endoprosthesis. But if this is the result, this is not what we wanted to do, okay? So nowadays, this prosthesis is thought for patients in which you want to do only ascending aorta replacement that has no problems in the arch and also has malperfusion. So at least you open a little bit more the true lumen to make it a little bit better. So in conclusion, I would say that the replacement of the ascending aorta and hemi-arch nowadays is the one with better results in short term and even in long term, except of the need for reoperations. And the total arch replacement in America and in Europe, it's basically in problems with the arch. And this is what we are doing also in my hospital: tears in the arch dilatation on arch rupture, and also in young patients with connective tissue disorders, Loeys-Dietz, Ehlers-Danlos, Marfan, etc. New prosthesis for a frozen elephant trunk in zone 0 or 1, we have them, or zone 0, like the Fontus, which is an easier technique, but at this moment, they have not shown better results than not replacing the arch to a distal point. So it's easier technique, but still with the same problems, and not better than the replacement of the ascending aorta or the hemi-arch. And finally, this new open stent in the arch prosthesis that is indicated for malperfusion patients and with no problems in the arch, only that you want to replace the ascending aorta. And remember that may have these problems of almost 10% of severe kinks of the prosthesis or even prolapse. And basically, this is the information that I wanted to give. Thank you very much for the opportunity and for the invitation, and it's a pleasure to be invited in this symposium. Thank you.
Thank you very much, Dr. Castella. It was a wonderful overview, and we have learned a lot. Perhaps we can have the discussions at the end and the questions at the end. If Dr. Ming, who is ready to give the second lecture, do you think? Or Dr. Hian? Okay. So we invite Dr. Shong Hian to give his lecture on proximal repair versus extensive repair in acute type A aortic dissection. The more, the better. Yes, please.
Okay, please.
Can you make it full screen?
Can you see the PowerPoint?
Yes,
钱教授，您这边没问题。
Yeah, we
It's
can
okay.
see your slide. Okay.
Okay.
Please.
Good evening, everyone. It's a pleasure to be here with you today. I'm Sichong Qian from Beijing Anzheng Hospital, and my topic is also about the proximal repair versus extensive repair in acute type A dissection patient. The more, the better. We will learn something from that. The treatment strategy for the aortic arch in the setting of type A dissection is evolving as improved surgical techniques. No doubt that the introduction of advanced technology such as the total arch replacement with standard elephant trunk has improved our ability to manage complex the arch pathologies. But does this mean we should do the extensive repair on all the patient with type A dissection? If there is no primary entry in the aortic arch or the descending aorta, then should we dissect all the arch vessels and perform total arch replacement in an emergency situation? we made an effort to demonstrate that. We collected clinical data of more than 5,000 type A dissection patients from 13 Chinese hospitals during 2016 to 2021. This cohort were separate in two groups, proximal versus extensive group. The proximal repair was defined as the ascending aorta procedure with or without hemorrhage replacement, and the extensive repair was defined as the ascending aorta procedure combined with total artery replacement and the standard elephant trunk implantation. The primary outcome of this research was operating mortality, defining as any death, regardless of cause, occurring with 13 days after surgery in or out of the hospital, and after 13 days during the same hospitalization subsequent to the operation, according to the Society of Thoracic Surgeons criteria of United States. In this cohort, the overall operating mortality was 8.3%, and the 4.1 in the proximal group, and the 10.9 in the extensive repair, respectively. Next, we pro-patient matched them and conduct a logistic regression to estimate the order radio of the operating mortality. The top 7 features of importance were age, body mass index, platelet to leukocyte ratio, albumin, hemoglobin, serum creatinine, and male perfusion were selected with the optimized gradient boosting machine learning library to develop a risk prediction model to predict the operating mortality. The dataset from the 7 hospitals were used to develop a derivation model, and the rest data from 6 hospitals were used to externally validate the model. This is the result. We can see that the observed the mortality of the proximal and extensive repair increased progressively as the predicted operating mortality risk grow. We can see the horizon line. The absolute rate difference in mortality between the two repair strategies increased progressively as predicted risk rose. It did not become statistically significant until the predicted risk exceeded 4.5%. After additional adjustment, the result was still similar. Based on the result and the existing literature, we present a potential surgical strategy plan for type A dissection patient. If the stratification shows the patient at low risk, the choice is hand over to the location of primary entry in ascending aorta. The proximal repair may essential. Otherwise, extensive surgery is preferred. Parallelly, the extensive repair is not recommended in high-risk group, no matter where the primary entry is, though the proximal repair only show the non-inferiority compared with extensive repair when the location is ascending aorta. Alternatively, the solution like hybrid surgery may be more safe on the last situation. The potential benefit of proximal repair need to be weighted against the drawback of long-term survival and reinvention. In previous areas, the surgical goal of type A dissection patient was to prevent the high 48-hour mortality by repairing entry and occurring false lumen. But now we have to weigh the potential of improved long-term survival and the lower reintervention rate associated with the total arch replacement against the lower operating mortality associated with the limited repair. We provide a potential strategy plan on the basis of data. However, a lot of the factors that not belong to clinical characteristics also have impact on surgical strategy in reality. We have to take all this into consideration. Of course, the surgery is a matter of technology, but the medicine is a matter of sociology. Actually, they both strategies are likely to be appropriate in the right hand and in the right patient. But the issue is how we define the right patient. Our study was to collect some objective features, find some common characteristics, and establish a strategy plan to help acute type A dissection patient escaping from the operative death. We provide the right patient in the sense of peri-operation. However, we are unable to comment on the differences in long-term mortality, the rate of reintervention, and the mobility between the cohort undergoing proximal and extensive repair. The precise long-term follow-up result, the development of AI, may help us totally address this in the future. Dr. Gleason, the chef of division of cardiac surgery in Pittsburgh University, reported their study on a type A dissection patient with the cerebral malperfusion in 2019. They demonstrate that in hospital mortality over 25%, the cerebral accident nearly 20%. The type A dissection patient complicated with the cerebral malperfusion suffered from significant higher risk of surgery than others, but they told us it is still reasonable to offer such a life-saving surgery for them. Of course, the mortality of the patient treated with medical manager were extremely higher than the surgery. We have to do the surgery for this patient. Even the mortality is higher. For now, without sufficient evidence, we cannot make a final judgment on the basis of simply rational model, rather than say the more the better or less is more. The most aortic surgeon would probably continue to assert that we must do what needs to be done for this patient on the table. The decision we made is still on a case-by-case basis, taking into account specific factors of the patient. And that's all. Thank you for the chairman. Thank you for all the experts. Thank you for the ceremony. That's all. Thank you.
Thank you very much, Dr. Kian. It was a wonderful talk. I think we will have the discussions at the end, and probably you will be discussing with the Manuel Castella to have the right the decision on this extensive or proximal surgery is the best. So now, Dr. Gong,
Yeah, I'm here.
would you like to introduce this?
No problem. I will introduce Dr. Sun. Yeah, Dr. Sun is very famous surgeon of the in China. He is now in the Guangzhou province, and he is a very famous aortic surgeon in China. And next, he will give us his slide, and his title is Update on Type A intramural hematoma, does it always require surgery? Please, Dr. Sun, the floor is yours. Professor Sun, can you hear me?
Yes,
Okay.
I try
Thank
to
you.
share my screen. 这个吧。
Okay, Professor Sun, we can see your slide and you can show your slide in total screen.
Sorry, excuse me, professors. 孙教授，您现在是在这个演讲者模式，您在左上角那里，就是看是否可以调一下，它应该是可以。您是两个屏幕共享的话，您现在共享的这个是演讲者模式的，您需要调换一下屏幕才可以。
怎么样调配？我看看啊。好的，好的。现在可以吗？ Okay, good evening. Thank you for the opportunity to speak. My title poses a deliberately provocative question. Does type A intramural hematoma always require surgery? In the next 20 minutes, I will work through the evidence, including 3 studies from our own group, and offer what I believe is a dispensable answer. 这个下一页怎么做？ It's done. I have nothing to disclosure. Let me begin with the disease itself, definition, classification, natural history, and current guideline landscape. Acute aortic syndrome has an incidence of 3.5 to 6 per 100,000 patient years, and comprised 3 entities defined by loss of arterial wall integrity, aortic dissection, intramural hematoma, and penetrating atherosclerotic ulcer. Intramural hematoma is medically hemorrhage from rupture of the vessel distinguished by the absence of intimal tear and fast lumen. IMH represents 5 to 25% of acute aortic syndrome in Europe and the United States, but 20 to 50% in Asia, a geographic difference that recurs throughout this talk. Type A IMH accounts for 30 to 40% for all IMH. The mechanism is hemorrhage from rupture of the vessel within media, which enlarge the aortic diameters as blood accumulated in the wall. This is the anatomic basis for the imaging parameters we are relying on: wall thickness and the aortic diameter. The natural history is genuinely variable across the literature. Roughly 3 34% of case undergo absorption, 30% involved to an aneurysm, 12% progress to dissection, and 6% to rupture. This heterogeneity is precisely why a single mandatory treatment for all patients is difficult to justify. Western guidelines converge on surgery. The 2022 ACC/AHA guidelines give the prompt open repair for uncomplicated type A IMH class 1 recommendation. And the 2024 ESA guideline likewise recommends urgent surgery for type A IMH class 1. And 2024 EACTS guideline recommends emergency surgery for type A IMH with a complication or high-risk features, class 1, level B. Asia take a different position. The JCS guideline notes that in Europe and the United States, type A dissection with thrombus false lumen is operated on, and for its high recognition rate and poor prognosis. But that in Japan and South Korea, conservative treatment under strict management has become feasible for patients with an ascending diameter below 50 millimeter and false lumen thickness below 12 millimeter on the basis of accumulated evidence. This table summarized the key comparative literature. Kaji 2002 found IMH in hospital mortality far lower than that dissection, 7 versus 34%. Last year, 2005, I read analysis found IMH mortality similar to classic dissection, 20.7 versus 23.9%. Song 2009 found no survival difference between IMH and surgical treatment dissection. Harris 2012, I read analysis report 40% no mortality with conservative IMH type A IMH. Kitamura 2020 found no difference between medical and surgical management. And our own Young 2021 series found equivalent early mortality but significantly higher late mortality in the conservative group. Peter's data make the East-West contrasted quantitative. IMH constitute 10.95% of the acute aortic syndrome in the United States, Europe cohort, versus 31.7% in Japan, Korea. Early medical treatment was used in 48.8% of Western cases versus 77.9% in Asia. Critically, mortality with early medical treatment was 33.3% in the West, but only 7.8% in Asia. And overall mortality was 20.6 versus 9.4%. The conclusion is direct. There is a significantly international heterogeneity in the diagnosis and the clinical outcome of the ascending IMH. IMH is diagnosed more frequently and it has better overall outcomes in Japan and Korea. Kitamura asked whether a watch and wait strategy is justified in the type A IMH and thrombosis false lumen dissection of the ascending aorta, with diameter at or below 40 millimeter, pain score at or below 3 out of 10, and no ulcer-like projection. pericardial drainage was required in 20%, aortic repair in 7%, and hospital mortality was 4%. The take-home message was watch and wait is reasonable in the Japanese population to meet those criteria. Lee examined the IMH involving the ascending aorta and examined it into the descending thoracic aorta. 135% patients, single center. At 5 years, TIVA achieved 84% freedom from adverse aortic-related events, versus 74.2% for medical therapy. And 100% survival versus 81.9% excess adverse event cluster in the patient with renal insufficiency. Kim reported the standard experience 903 acute aortic syndrome patients, 214 type A MH and 919 type A dissection. Unadjusted score risk, 10-year survival and 10-year freedom from reoperation were similar between groups. After a judgment for personation characteristic type A MH had better 10-year survival. The message: surgical management of type A MH yields excellent postoperative outcomes. This is the fundamental IMH work. Kaji, in 22 type A IMH patients, defined the 2 parameters or we still use maximal aortic diameter, the outer contour diameter of the affected aorta, and the maximal hematoma thickness, wall thickness from intimal to adventitia. These 2 measurements has occurred risk stratification for over 2 decades. A recent multi-center study by Motoji examined earlier change in retinal thickness in 140 medically management type A IMH patients across 6 centers in hospital progression, new ULP, hematoma enlargement, false lumen recognition, or rupture occurs in 25%. Notably, only the MAD remodeling rate independently predict in hospital progression. 3 limitations frame our own work. First, most studies are single-center retrospective with no prospective cohorts and no external validation. Second, many include fewer than 100 MH patients. Third, prediction has relied almost entirely on MAD and MHT, 2 dimensions measures with a lack of more comprehensive evolution metrics. These 3 gaps map directly onto our 3 studies. First, retrospective comparative study of conservative treatment versus surgery. Second, prospective randomized compromised control trial, the timer trial. Third, prediction progression in the conservative group using the hematoma volume. I will present them in turn. First, our retrospective cohort of 224 patients from November 2011 to February 2023. After applying inclusion and exclusion criteria, we enrolled 224 acute type A aortic intramural patients. 138 underwent emergency surgery, and 86 patients were managed conservatively. In the second group, in the surgical group, the dominant strategy was total arch replacement, the Sun's procedure, in 63.8%. In the conservative group, 13 patients crossed over to surgery for disease progression. Inclusion requires the onset within 15 days. CTA confirmed the type A MH and acute aortic syndrome symptom. We exclude classic dissection within intimal interior of all fast lumen flow. Retrograde MH from type B origin, peria aortic surgery, and incompetent data. Median age was 61, and 77% were male, and no difference between groups. The surgical group had significantly more hypertension and coronary disease. The conservative group had more COPD, more smoking, and more connective disease, tissue disease, Marfan and bicuspid valve. This imbalance reflects real-world selection and matter when interpreting outcomes. The emerging difference are the crux. The surgical group has significantly more ULP. There is a 44.9 versus 29.1%. Longer ascending aorta, 12.1 versus 9.4 centimeter. A larger maximum aortic diameter, 44.8 versus 41.7 millimeter, and substantially greater hematoma thickness, 13.7 versus 8.0 millimeter. Patients selectively selected for surgery already carried a higher risk anatomy at the baseline. Among the 138 surgical patients, the Swiss procedure dominant in 88 cases, or 63.8%. The next most common were Swiss procedure with aortic valve replacement in 15, Bento in 6, and TIVR in 7. The remainder compromised various hybrid and combined procedures as shown. Overall, in hospital, mortality was 15.2%, 34 out of 224. By group, it was 14% conservative versus 15.9% surgical, with no significant difference. 5-year survival was 19.1% conservative versus 83.5% surgical, with no significant difference. I would caution against overreading the numerically higher conservative survival. It may reflect lower baseline risk of the conservatively selected patients, not a treatment effect. This is the key caveat. 13 patients, 15.1% required surgical conservative for disease progression during follow-up, and freedom from progression curve declines steadily. The clinical message is ambiguous. Conservative management is only safe with stringent dynamic CTA surveillance. 3 points on risk stratification. High-risk imaging features were more prevalent in the surgical group on efficiency. Conservative management achieved similar middle-term survival in selected stable patient, and implication individually individual guide management with strict surveillance may optimize the treatment selection. The retrospective data were hypothesis generating, but confounded by selection. To address that, we designed a randomized trial. Three premise motive the trial. Optimal treatment for type A MH remains controversial. Current guidelines are in constant, and higher quality randomized data are lacking. Importantly, none of the prior studies clearly separate the complicated from uncomplicated MH, which we believe drivers the inconsistent funding. The objective to compare best medical therapy versus surgery in uncomplicated type A MH. We define the complicated disease, and therefore the inclusion as follows by 7 criteria: persistent or recurrent pain despite aggressive treatment, difficult blood pressure control, maximum aortic diameter or at or above 50 millimeter, maximum hematoma thickness at or above 11 millimeter, malperfusion, moderate or severe pericardial effusion, and the presence of penetrating ulcer or URP. Patient with only any of these were excluded. The primary outcomes were early mortality and late mortality. All cause deaths excluding early deaths. From the medical therapy arm, secondary outcomes were aortic intervention, progression to type A dissection, or progression to complicated type A IMH. We used the Bayer non-inferior design from the institutional hospital surgical data. 7 deaths in 83 patients. We set a beta barrier with alpha 7 and beta 76 for the surgical event rate. Assumed to 10% conservative event rate and applied a non-inferior margin of 10%. Simulation with beta binomial conjugate model shown that 40 patients per arm satisfied the criterion in at least 95% of 10,000 simulated trials, a total of 140 participants. The trial runs from January 2021 to March 2025 and registered in China. Mostly for wall thickness at or above 11 millimeter or diameter at or above 50 millimeter. 82 were randomized, 44 to best medical therapy, and 38 to surgery. In the medical arm, there were 3 early deaths, 2 late deaths, and 23 progressions. In the surgical arm, 2 early and 3 late deaths. The 2 arms were well balanced: age, sex, comorbidities, ascending aorta length, diameter, and hematoma thickness showed no significant difference. Overall, early mortality was 6.1%, 6.8% in the medical arm, and 5.3% in the surgical arm, with no significant difference. But equivalence in the surgical considers the burden of progression. In the medical arm, 52% meet progression criteria. Critically, 78% of those progression occurs within the first 3 months. About 20% involved into type A dissection, and 38% ultimately received surgery. Medical therapy is not a stable endpoint. It's a closely monitored pathway. Comparing stable and progressed patient within the medical arm, age, sex, and most comorbidities did not differ. The significant predictors were ascending aorta length, 106 versus 96 millimeter, maximum diameter, hematoma thickness, and notably hypertension, hyperlipidemia, which was far more common in the progression group. These are markers that show a heightened vagueness. 3. Conclusion. For uncomplicated type A IMH, surgery is recommended in experienced centers, given the high progression rate. In low volume centers, conservative management with close surveillance may be considered, particularly through the first 3 months. And in conservatively management patients, aortic length, diameter, hematoma thickness, and hyperlipidemia in identity those who warrant a more aggressive approach. This brings me to our most recent work, moving beyond 2-dimension management to volumetric prediction. We studied 318 acute type A MH patients from 2013 to 2025, 108 conservative and 210 surgical. Within the conservative group, 47 progressed and 61 patient remained stable. For each patient, we performed the 3-dimensional segmentation for the hematoma, dividing not only the conventional MHT and MAD, but a new parameter, hematoma volume, HV. Comparing progression and stable patients, we define the difference is striking. MAD differs, but only 1.1-fold, versus MH by 1.2-fold. But hematoma volume differed by 3.0-fold, 49.6 versus 16.7 cubic centimeter. Volume separate progression from non-progression far more sharply than either axial measurement. ROC analysis confirms this. The area under the curve was 0.78 for MAD and only 0.668 for MHT, but 0.881 for hematoma volume, the best of the 3. The optimal HV cutoff was 34.46 cubic centimeters. Volume is the superior discriminator. We therefore define high-risk features, combine the guideline threshold with our volumetric cutoff, MAD and or above 50 millimeter, and MHT at or above 10 millimeter from current guideline, plus HV at or above 34.46 cubic centimeters, and the optimal cutoff from our ROC analysis. On progression-free survival, all straightforward were significant, but their strength differs. Higher HV shows the strongest separation. The hazard ratios quantify this at the cutoff of 50 millimeter. MAD gave a hazard ratio of 5.9. At 10 millimeter, MHT gives only 2.06, and HV at 34.5 cubic centimeter cutoff gives 4.78, comparable to MAD and far more MHT. The key point, both MAD and HV are strong predictor of progression, whereas the MHT shows a weaker association. Applying the combined traditional high-risk definition, MAD and MHT, high-risk patient progressed at 60.5% versus 28.3% in the low-risk. Surgery conservation, all-cause mortality, and aortic-related mortality and did not differ significantly through aortic-related mortality trend higher in the high-risk group. The combined criteria clearly separate the progression risk. But volume alone is even more powerful. Among HV high patients, 92.6% progressed versus only 23.8% of HV lower patients. Nearly every high volume patients progressed. Hematoma volume provides a risk stratification beyond the conventional combined criteria. In the full cohort, we compare the conservative group with the surgical group. The imagine gradient is consistent across the stable, processed, and the surgical group. ULP, MAD, MHT, and HV all differed significantly. Hematoma volume is in stable patient, it was 16.7 cubic centimeter versus 49.6 in progression and 46.2 in the surgical patient. The progressor's volume essentially matched that of patient triggered directly to surgery. In the full 318 patient cohort, the conservative group had 14 cardiovascular deaths. That was 13%, and 6 non-cardiovascular deaths, 5.6%. The surgical group had 23 cardiovascular deaths, 11%, and non-cardiovascular 3.3%. Overall mortality is broadly comparable between the two strategies in this real-world cohort. This is the validation step. We applied the conservative derived the cutoff to the 210 surgical patients. Patients clinicians had already adjudged to need surgery. MAD flagged only 21.4% at high risk. MHT flagged 62.4%, but hematoma volume flagged 87.6%, by far the largest proportion. Volume identified the vast majority of the patient independently deemed surgical, which is the strong face validity to HV as a decision maker. Therefore, HV outperforms MAD and MHT, AUC 0.88, specifically 92%, positive predictive volume 88%. It's a hard ratio for progression exists 5, and it captures 87.6% of surgical patients. Let me bring the three study together. From the retrospective cohort selected a stable type A IMH patients achieved comparable midterm survival with non-conservative management and surgery. From the timer trial, given the high progression rate under medical therapy, surgery may be preferred in the experienced center. From the volumetric work, hematoma volume outperformed conventional markers and gave superior prediction of progression. The unifying message answers our title. Not always the immediate surgery, but always surgery or rigorous surveillance. I would thank you. Thank you all.
Dr. Gong?
Okay, thank you. Thank you, everybody, and thank you for Dr. Castella and Dr. Qian and Dr. Sun. Thank you for your share of your experience and your excellent research result for us. And I think we maybe have a lot of questions to discuss. So would you please give me some comment and some question for all our presenters? Thank you.
Mm-hmm. Let's start from Dr. Castella, probably. You have mentioned that new devices, and perhaps with those devices we have better result for arch replacement, total arch replacement. Do you think that under these circumstances we can prefer arch replacement more over the proximal only repair recently? And if so, which device do you prefer more?
Mm-hmm. Well, for almost 10 years, I've been a very advocate for a total arch replacement with the frozen elephant trunk, and this is what we have been using with the Thoraflex and now with the Evita. But the evidence on the trials and the randomized controlled trials show that there's no benefit we see almost pretty much the same mortality. But Dr. Kiang, for example, I enjoy very much. Well, I enjoy the two other talks very, very much. And I learn a lot. But Dr. Kiang, that had a similar topic, showed very higher much mortality with the total replacement of the arch. I think it was 11, almost 12 versus 4%. So that altogether make us think that even with the new prosthesis, even with the help of these new prosthesis, that we can do the anastomosis closer to us, like in zone 1. Zone 1, just to remember, is between the brachycephalic truncus and the carotid artery, or even in zone 0 before the aortic any aortic branch. Nevertheless, since we need to do the anastomosis, single anastomosis for every branch, if we need to replace the arch, then that is what it increases probably the mortality. So this new prosthesis makes things easier, but we still more data with randomized controlled trials showing what if I do the anastomosis very, very close to me? What if I do the anastomosis in zone 0 or zone 1 versus hemi-arch? Basically, it's almost the same type of anastomosis. Let's see these two in comparison to hemi-arch. And probably we still lack this data. But nowadays, I went back to my strategy, went back to only replace the hemi-arch. And I want to tell you another thing that happens to all our surgeons. It's not only me. Is that if we have problems on the aortic root, because we have not talked about the aortic root today, But if we have problems in the aortic root, like for example, broken coronary ostia, very bad aortic valve in which we do have to do a Vental or a David or a Jakub or things like this, if we need to be very aggressive on the root, we usually mentally, we are not going to be very aggressive on the arch because we already have a lot of problems on the root. And when the aortic root is okay, so it's a very easy thing to replace the ascending aorta, then we tend to be more aggressive on the arch. But as I tell you, it's there's not so evidence, and the evidence that we have now is not so much to replace the arch, not even with a new prosthesis.
Yeah.
I don't know the opinion of Dr. Kian because he made a wonderful research as well on this topic.
Yeah, what do you think, Dr. Kian? Should we, at the end of the day, should we behave more conservative for arch replacement or?
That is the question. This is the question.
Yeah.
Should we just keep ourselves to repair the proximal site only? Dr. Kian?
Chen, Sichuan.
Oh, thank you for Chairman. But sorry for I can just follow your what's the question?
Do you think that we, at the end of the day, now we have to be more conservative on reconstructing the arch, or should we, because we have new devices as well, or do we keep ourselves, have to keep ourselves at the proximal repair only?
Okay. Of course, as a surgeon, as a researcher, we have to be original. We have a model. We have we have AI to help us to make a decision. But as a surgeon, we have to say, most time, just like the catheter, most time we do the surgery just on the circumstance in reality we must do the surgery step by step. We make we could make a plan, but on the procedure we must do they we meet the I would say we make the very precise the plan strategy, but on the circumstance of the procedure we just meet the problem and solve the problem. So in our opinion, we don't like to do the more aggressive the procedure on the when the older the patient with the malperfusion. We don't want to do the more aggressive the procedure on this patient, because the most thing is to help patient to escaping from the death. If the patient will suffer death from the operative peri-operation, there's no long-term survivor. So the most thing I thought as a surgeon we should take into consideration the most important thing is the help patient survivor from the operation. So we on the most circumstance we choose not to do the more aggressive procedures. That's my opinion.
Yeah, we fully agree. We fully agree.
Okay.
The best is to discharge the patient.
Yeah.
Dr. Otto, in China, that is especially that our patients, the age is very young. the average age only from 40 to 60 years old. So the average age of the patient may be 50 years old. So we not only to consider the early result of the patient, so we need to consider of the future of the patients. So we maybe the rate of the totally arch replacement may be very high in China. So follow this result. So I have a question for you, Dr. Castelli. So I see that you have a new equipment of the hybrid to do total arch replacement. So if we do the hybrid the operation in the future, if the patient's descending aortic dilate, so maybe we need to replace all the total descending aorta. So the new equipment can adequate for the totally descending the aorta to replacement in your center.
You mean the last prosthesis that I showed, that it was the open stent?
Yeah.
Yeah. Well, there's no, this is not planned. This is not planned for a future landing zone for a retrograde endoprosthesis. Okay, if that is what you are asking, that would be good to have this open stent, and then from years after or months after, come with another stent prosthesis and put it in. The only thing is that since this is open, it has not shown that to cover it does not cover the arch, and the arch can still dilate. So it's not been thought to put a stent, and there's no reports of putting a stent. Sooner or later, someone will put it, but it's not planned for this, and it's not been used yet. But your idea is not bad. It's not bad. The only thing is that it will be kind of a mixed procedure, because they will have a dacron in the ascending aorta, only an open stent in the arch, and a dacron endoprosthesis in the thoracic aorta. It may work, but at this moment, I have not heard of any description of this, because it's not planned for this. It's not planned, and it's a very soft stent. In fact, as you can see, that it can kink very much. Okay, it's only to expand a little bit the endoluminal aorta to try to solve malperfusion. But your idea in the future, it might happen, yes. And I'm surprised that you have aortic dissections in such young population. We are more aggressive in young population, so probably we would do more arch replacements in a 50-year-old patient, for example. So yes, this can be a change in like in the last presentation, in which there was different treatment in Asia than in Europe and America, for example. That's interesting.
Dr. Sun, really you have presented very nice research. I think three research, and in most of them, in general, a conservative approach was better than probably aggressive approach, especially for less than 50 millimeters of diameter, and the thickness of the if the thickness of the wall less than 10 millimeters. So especially in 3 months follow-up, do you always recommend just conservative follow-up for intramural hematoma? Can we take this as a take-home message? We cannot hear you.
黄主任，您没开麦克风。
Dr. Otto is asking Dr. Shun.
孙主任，您没开麦克风。
Yeah, he want to know the take-home message. Yeah.
你来回答吧，要不没事，你来回答。I will ask my colleague to answer better. Yeah.
Dear professors, this is our early results to compare the conservative approach versus surgery in uncomplicated type A IMH. There might be some misunderstanding. You said that the conservative cohort achieved better results, but our results actually shows the conservative and surgical group, they show the similar results. There's no significant difference, but the progression rate is really very high for the conservative cohort. So the key message is for experienced centers. I think those you guys are very experienced surgeons. With your hands, you can to recommend surgery for type A MH with high confidence. But for those smaller centers, they could recommend the patient for conservative cohort or transfer to tertiary center. That's the message. Thank you.
Yeah, wonderful take-home message you have given. Thank you very much. So with this, I think we can come to the end of our session. I would like first to the society for giving the opportunity of presenting such a wonderful session. And secondly, I would like to thank to my co-chairman, Dr. Min Gong, and the speakers, Professor Castella, and Dr. Cheng and Dr. Kian for their excellent presentations. Thank you very much for all followers as well, which I have just heard that it's over than 700 in Asian side and 200 at European side. Thank you very much for all followers as well. Thank you. Bye-bye.
Thank you, Otto.
Thank you.
Wonderful
Bye-bye.
weekend.
Thank you very much.
Thank you.
It was a pleasure.
If
Thank
you come to
Thank you
Beijing
very much.
for the Great Wall conversation this year.
Probably yes.
So, do we still have like 5 minutes left? I want to ask Dr. Castella a question.
Okay.
Yes.
Okay.
Yes.
Yeah.
So this is a very impressive session. Okay. So Dr. Castella give us a presentation, compare the different area, different procedure. So in China, it's very impressive. We have like more than 85% using total arch replacement. And the mortality is very, very impressive, like 5%. So like in Fuwai Hospital and Anzhen Hospital. But in Western countries like European and American, so like the Aortic database, so the mortality is like double, like more than about 15% mortality. So in any stage, in any stage as a aortic surgeon, so I like hemi-arch or ascending arch. So the mortality is fine. So as I am learning and some young patient that need the total arch replacement, even in our center, so the mortality is about like 7 to 8%. So I want to know in European country the leading cause of death of the type A dissection. So if the mortality is very lower, will you like to do total arch replacement for the patient? So this is my question.
Yeah, well, very, very, very nice question, because I see that it's the setting is different from at least China than in Europe. First of all, our patients are, many of them, they are, most of them, they are over 60 years old, and many are over 70. And many times in this older population, any single thing makes it that the postoperative period goes wrong. Like, for example, there's more renal insufficiency, more malperfusion. So that makes it because we pretty much solved the problems of the surgery by itself, the bleeding and all of these, or the ejection fraction and all. This is not a problem so much. There are more strokes as well in the older population. So that makes it, might be a difference. The other difference maybe is the hospital settings. We have a lot of hospitals in Europe doing not so much procedures. Like many hospitals, we're doing 500 cases, 1,000 cases. Like my hospital only does 1,000 cases, and in China, for example, there are all these centers with 20,000 cases per year, and so maybe the experience of these aortic surgeons in China operating so many patients is better, and then they have. So maybe it's a patient of the patient that it's younger. Maybe it's the experience of the surgeons. So there might be many factors, but it's true that, but nevertheless, Dr. Qiang showed a very interesting study showing that ascending aorta replacement had 4% mortality, total arch 12% mortality. So it was more than double, almost 3 times the total arch in China. Still not very much mortality, because it's described in Europe and in the USA 13-15% mortalities. So in these studies, Chinese studies, they have lower mortality. Yeah, because of these factors. If I would have mortality less than 10%, I would go in for total arch. And if I had your population of very young people, very young patients, I would also do more total arches. And in fact, for many years, I did always total arch, but now I went back to hemi-arch in many cases. Basically, if the patient is very old, I want a quick surgery, not go down so much on temperature, and finish the surgery fast.
So a wonderful last question and a wonderful response. Thank you very much once again. Have a good weekend. Have a wonderful weekend. Bye-bye for now.
Bye-bye. Thank you.
Thank you.
Bye.
Thank you very much.
Good weekend.
Thank you.
A
Bye.
pleasure.